All right, maybe we can get started. So if you haven't met me, I'm Anna Romani. I'm one of the general internists at St. Paul's Hospital, but also uh, obviously do thrombosis at St. Paul's. So it's my absolute pleasure to welcome Dr. Sarwal. He is a UBC trained vascular surgery attending who joined St. Paul's Hospital in 2020. He had a fellowship in interventional radiology and has been cross-appointed both at the surgery as well as radiology departments as a new attending staff. Given his surgical and endovascular skills, he's been bringing together the specialties of radiology, interventional radiology, and vascular surgery together, and we're quite excited that he's here to blend those two subspecialties together. He's most recently identified a need for us to address acute PE management, and similar to other algorithms that have already been established at Vancouver General and Surrey Memorial and RCH. So if you happen to have been at the grand rounds this afternoon, that was also another PE work that really brought about the need for us to communicate, to form networks, and establish really strong relationships with our interventional and vascular surgery colleagues. So without further ado, I'll pass it over to Dr. Sarwal, who's going to talk about acute PE management. Thanks very much for being here today.
Yeah, thank you everyone again for being here. And Dr. Romani, thank you again for the invite and for the kind words. My name again is Gotham. I'm one of the new staff here in St. Paul's Hospital, and I work in several departments, two of them being vascular and the other one being IR. So I'm very, very lucky to be a part of this talk and of this initiative from both the IR side of things and I guess a little bit from the vascular side of things as well. I also have a smaller role to play with cardiac, specifically around ECMO. So it kind of makes me the perfect liaison for this talk because PE is something that involves all three departments in some level or the other, and also not to mention our colleagues in ICU, Emerge, and thrombosis as well. So with that, I was asked to give a talk on the up-to-date PE management in patients with acute pulmonary embolism. So I'm giving this talk really based on a very limited experience that we have at St. Paul's with some of the newer devices, but we are gathering that data, we are gathering that experience, and it can only grow from here if we recognize those patients, get those referrals early, and get those conversations started early. Because from time to time, I get these informal consults as text messages to my phone along the lines of, "Hey, do you do this?" As opposed to it being a very structured and standardized approach. And that's kind of what I wanted to set up for our hospital as well. And we'll talk about what some of the other centers are doing and have done for this. These are some of my disclosures, nothing specifically that's relevant to this talk. I have received some travel stipends from various other interventional agencies, but again, nothing specific to this talk. So really, we're talking about three different types of PE here. There's low-risk PE, the so-called intermediate risk PE, or the submassive and the massives. And I think everyone has some idea as to what this entails. But we are really referring to two categories of PEs here. And one is the massive group, which are the critically ill population, and then the intermediate high-risk group within the submassives that we're going to refer to in this talk. The management of the low-risk PE, I believe, still remains very much ambulatory care, and I'll leave that in the hands of the thrombosis team. So I think where IR, ICU, Emerge all intersect is in that latter cohort, which also thankfully happens to be a smaller group as well. So I think the biggest reason we want to address this, or at least I think it's important to address this, is because the mortality in PE has not really improved over the years. It's these are very sick patients, very ill patients, and I kind of want to spend the next half an hour talking about what the current guidelines are and bring us up to speed on those, and then spend the latter half of the session talking about cases that either we've seen at St. Paul's from a catheter-directed standpoint, to a aspiration standpoint, and then to cases that are seen by my colleagues at other higher volume centers such as RCH and Surrey Memorial, and specifically cases from a colleague of ours, Dr. Herji, who very kindly has joined us as well, and can also attest to some of his experiences with the newer devices as well. So I wanted to thank him again for lending us some data and some of his patients and cases so that we may all reflect upon them. So the mortality in these patients, especially the high risk PE, the massive PEs, can be as high as 50% at the 30-day mark. So these are very critically ill patients, and we want to provide them with options for clot removal besides just thrombolysis, which, as we know, has its own issues around bleeding and coagulability disorders. Now, the question is, why is this important? So when it comes to PE management, it's not just the breakdown of the clot, but really the clot evacuation that's really become the focus of research today. And the reason of this is that research has shown that rapid unloading of the ventricle and improved thrombus clearing allows for better cardiopulmonary remodeling, and it specifically targets that RV in the right ventricle, from which it's linked to a almost downward spiral once you start seeing evidence of right heart dysfunction. And patients who have this post-PE syndrome have morbidity with this, everything from ongoing shortness of breath, pulmonary hypertension, pulmonary outflow stenosis, to right-sided heart failure as well. There are certain predictors of adverse events from PE, everything from having a large clot burden, a central clot burden, so that's saddle PE, having a concomitant DVT, and having that residual obstruction. So that's where we start to shift from just anticoagulation and thrombolytics to actually active clot extraction. And that's going to become the theme of the newer devices that I'm going to refer to as well. That central clot burden, that large clot burden, all of them are linked to higher mortality. And again, we want to target this specific population of patients as well. We've seen this in the literature as well, that patients still have residual clot, even if you do get them on anticoagulation or traditional thrombolysis, whether it's IV or catheter directed. And it's that residual thrombus that leads to that post-PE syndrome and that future morbidity, even if they do get discharged from your hospital. And so this is some data that shows a comparison of patients who do have the residual occlusion versus those who don't have any residual occlusion. And you can see the numbers are very obvious. The mortality is higher, the association of dyspnea, the heart failure, and the recurrent DVT-PE incidence is that much higher in these patients who do have residual disease, that you may not see it clinically, but you will see it systemically and symptomatically in future follow-up. This is a very common, you may see many diagrams such as this when they talk about PE management, and it's very institutionally specific, but this is a very standard diagram when it comes to PE management, when it talks about low risk versus intermediate risk versus high risk. And then really what it boils down to is, how does your own center approach these so-called high risk and intermediate risk patients? First of all, the question becomes, who is intermediate risk and who is the higher version of the intermediate risk? And the second is, what does primary reperfusion mean to you? Is it IV thrombolysis? Is it catheter thrombolysis? Or is it the now newer techniques of clot aspiration? And that's kind of what I want to delve into. Specifically the pathophysiology behind the PE being that right ventricle obstruction, and that becomes a downward spiral in itself, leading to obstructive shock and having that afterload, having that RV ischemia and hypoxic injury. And again, we'll see this sadly in a case I'll present eventually as well. One of the big things I found is that there's guidelines. There's no dearth of guidelines. I've had a chance to work with one of our new ICU staff on this, Duncan McGuire, who gave the talk this afternoon at St. Paul's for the ICU Grand Rounds. And there's no dearth of guidelines when it comes to managing PEs, everything from the European Society to Thrombosis Canada. And so what I'm going to spend the next few minutes is talking about some of these guidelines, specifically around low, intermediate, and high. So not to spend too much time on low, but I think it's very clearly recommended and very well agreed upon that it's outpatient management with anticoagulation with no indication for thrombolysis. Now's when the waters get a bit murkier, is when you look at those submassive intermediate risk PEs. The actual recommendation from the European Society is actually not to favor thrombolysis. But if you look at the remarks after, it says the thrombolysis can be considered in younger patients who are at lower risk of bleeding. So there is that gray zone, and that's where that institutional specificity comes up, is we need to have an approach as to what our institution agrees on. What do all our players agree on? Is who are these patients who are quote unquote low risk of bleeding, and who is a good candidate for thrombolysis? Because the evidence seems to suggest that we can approach these intermediate risk patients with thrombolytic techniques in addition to anticoagulation. It's not recommended, but it can be considered in a special subset population. If you look at high-risk PE patients, so the question then becomes, should thrombolytics be used in addition to anticoagulation? And the answer is strongly yes, it should be used. But now the question becomes, is it systemic thrombolysis or is it catheter-based thrombolysis? Now, this recommendation was based on a very wholesome review of multiple RCTs and systematic reviews. The problem being a lot of these patients were intermediate rather than high risk. And the majority of these trials looked at systemic TPA versus catheter-directed thrombolysis. Now, numbers that we should all be quite familiar with is when you look at thrombolysis over just anticoagulation alone, certainly there's a mortality benefit because of that clot breakdown, improvement in outflow, improvement in reperfusion, but there is that increased risk of bleeding as well. The question then becomes, what about systemic versus catheter-directed thrombolysis? We heard about this afternoon at the ICU talk as well. Unfortunately, no difference between systemic versus catheter-directed thrombolysis when it comes to the end result of a clot breakdown and clot clearance. So then the question then becomes, what about catheter versus systemic in patients in whom thrombolysis is actually indicated? And once again, because of the lack of clear literature to suggest that one is better than the other, the recommendation still sticks on that we continue with systemic thrombolysis over catheter-directed technology. But once again, if you look at the fine print, it says in centers with the appropriate infrastructure and human resources, catheter-directed thrombolysis can be considered. So the question is St. Paul's such a center? There are other papers along the same topic. So in the CMAJ, there was a paper looking at adults with intermediate to high-risk PE, comparing CDT to systemic TPA, and these are some of their findings. So in this review, they combined a systematic review, an RCT, and 3 studies. They looked at patients with intermediate and high-risk PE, and they did find that when you apply catheter-directed thrombolysis, you see a reduction in mortality. You do see a reduction in bleeding risk. It's not definitive, but they see it in sub-cohort analysis. There is a higher cost to this. There is a higher manpower cost to this as well, given the need for an interventional suite to be opened up. The conclusion of the study was that there's a conditional recommendation favoring catheter technology in patients in whom thrombolysis is recommended, but this is low-level evidence. So once again, we cannot definitively say that catheter thrombolysis is better than systemic thrombolysis based on this study alone. Now, like I was saying earlier, there's guidelines depending on who you look at and who you want to believe. So I'm a surgeon, but I'm also an interventionalist. So depending on what hat I wear, it can be a different recommendation. If I look at the critical care guidelines, this was published in one of the critical care journals, is similarly, it's a slightly different. So they look at the same as high risk, massive, and the crashing massive patient. There is a little bit of a difference. So they look at using systemic thrombolysis, and if there's a contraindication, then they move to catheter-based technology. So it really depends who you look at. And I think that there's never going to be a clear black and white answer. But I think the best thing we can do is, given the low number of patients that present with this, is have that discussion as a team and decide what strategy of clot removal is favorable. Because we have seen that removing that clot, improving that RV function, does give some degree of mortality benefit. So in final European guidelines, again, class 1 level B evidence saying systemic thrombolysis is recommended. We know that it works in high-risk patients. Catheter-directed technology works in patients who are at high risk, who are young, who have a higher life expectancy, and in centers where you have the capacity to do this. Again, this is a lower level evidence. So not a definitive answer. It's not yes or no. It's not black and white. It's still in the gray zone. And finally, if you're a center that has this technology, then ECMO may be considered. And again, St. Paul's is one such center. Now, before we talk about the cases, I just want to bring everyone up to speed as to the anatomy of this. So this is from a radiological perspective. What we're going to be looking at subsequent to this are pictures and angiograms. And what we're really focusing on, guys, is clot extraction, not from all the subsegmental branches, but really from the truncus, from the proximal upper, middle, and lower lobe branches, and the RPA and LPA. So we're not sending catheters down into those terminal subsegmental branches. That does not offer any benefit. I think what we're trying to do is gain rapid clot extraction, especially of those occlusive clots in the main proximal branches. So really right near the hilum. And this is what some of the subsequent pictures will show you. In terms of the newer technology, so we're moving now away from catheter-directed thrombolysis, which is very simple, very rudimentary. It involves either a jugular puncture or a groin puncture and a pigtail catheter that sits in the RPA and the LPA. And we're moving to more sophisticated technology, which involves aspiration and no thrombolysis. And one such product that we've acquired at St. Paul's is the Penumbra device, and the specific brand of it's called Lightning. And the numbers talk about the size of the catheter. So there's Lightning 7, Lightning 8, Lightning 12. And we have experience with this in IR from an arterial and venous perspective. So we use it to treat PEs. I use it as a vascular surgeon to declot thrombosed grafts. So we have a lot of experience with this technology. And now there's a 12 French device. And in the US, there's a 16 French device that's used for PEs. And I'll show you a case of how this gets used. In short, this is pure mechanical-based aspiration thrombectomy alone. So there's no thrombolysis. This is purely based on a garden hose being stuck in the RPA and LPA and that clot being extracted. This particular device has a proprietary technology. That little green box you see on top, it senses what's being sucked and it gives an audible feedback. So as an interventionalist, I can tell whether I'm sitting in clot or if I'm sitting in a blood vessel that's just purely full of blood, and so we're not getting blood loss. So this helps in mitigating blood loss as well in these kind of procedures. Another such device in the market, which is very rampantly used in Europe and specifically in BC, it's being used at RCH, VGH. I'm not sure about Victoria and Kelowna, but at least at these other higher volume centers, and that's Inari. And we don't have Inari as yet. We have applied for funding. To give you an idea, some of the older generation devices were in the $1,000 to $2,000 range. Penumbra is in the $6,000 range, and Inari is in $7,000 to $10,000 range. So it's very expensive technology, but I think we make up for this in the cost of using technology that doesn't require thrombolytics. We may not even require ICU admission after these such procedures. So we save on it from a hospital standpoint and from a patient care standpoint. But we do it in as the interventionalists have to deal with these costs. These are questions that we have to answer to our departments before using technology such as this. So Inari is another one such example. It's a 24 French device, so almost double the size of the Penumbra device. And once again, rapid clot extraction with no use for TPA. This is one example of a picture of what it looks like. It's got a sort of a mesh-like structure that helps fragment the clot before sucking it in. For completion's sake, this is a list of other devices that are available out there, and they may apply at your centers. But at St. Paul specifically, and I know at VGH and RCH, it's primarily Inari and Penumbra that's being used. Now, this is kind of what my Bruce, our finance representative, sort of asks me all the time is the finance side of things. Dr. Martin's my program and director and department head from IR, and that's his biggest concern is the money and the cost for these devices, the necessity of these devices, and ultimately what the long-term outcomes of using such technology is. So money is going to be a very big factor when it comes to treating these conditions. And I think from your side of things, the question is, what's the evidence behind it? These are all great toys that me as an interventionalist and physicians like Dr. Herji have available to us. But the question is this going to be useful? Is there any evidence behind using this? We heard from Dr. McGuire earlier today that the biggest issue is that a lot of these studies are industry sponsored. And as a result of that, there is a lot of bias. There's a lot of errors in system design, in allocation. But the problem remains that the volumes of these patients of high risk massive PEs are low. And so a lot of this is going to be based on clinical gestalt, on clinical experience. And at St. Paul's, what I can tell you is when there are cases that come up of PEs, they're often double scrubbed by physicians. And the reason for that is we want to increase our exposure. We want to increase our comfort with these procedures and these devices. So that multiples of us get that experience in working with these kind of patients. because it is very expensive and it's very difficult to gain that experience otherwise. It's not like your leg angioplasty or your stent, where you have multiple cases that are going to come through the door. So that's been the problem. And I think a lot of this is going to come to us relying on our colleagues at RCH, at VGH, learning from their experiences, learning from their cases. And I'm going to present some of those cases to you as well. So before we delve into the latter half of the talk, a little bit more on data. So the FLASH registry, this was the largest group of patients with PE that was analyzed. And this is both high risk and intermediate risk. The endpoints looked at were certainly device-related mortality, major bleeding, and any major adverse events in the first 48 hours, followed by long-term patient outcomes as well. Now, the numbers all look fantastic, and all these studies, they're fantastic. And I think a part of that, like I said, is also these are very industry-sponsored trials. But at some level, we have to believe some of these numbers as well. And the blood loss, if you look at it, is very low. Most of these patients had anywhere from 100 to 300 cc blood loss. You have these massive garden hoses that you're putting into the RPA and LPA to suck out the clot, and you're only losing approximately 200 cc's of blood per case. The procedural times are anywhere from 30 to 40 minutes. They don't require GA. They can be done under local. And in this particular registry, the mortality numbers are absolutely fantastic. 0% mortality in the first 48 hours and lower counts of bleeding and device-related mortality. Another thing that this has shown is that you get an immediate effect, a hemodynamic effect, as soon as the procedure is done. And I'll show you case examples of this. You get an immediate mean PA pressure improvement of up to 5 millimeters mercury. You get an immediate drop in heart rate, improvement in the blood pressure and RV function, and cardiac indices as well. The safety has been fantastic when it comes to using aspiration-based devices. This study specifically looked at the Inari device. Their mortality, all-cause mortality, was less than 1% at the 30-day follow-up and 2% at the 48-hour mark. So those are some very substantial numbers, which certainly cannot be ignored. The summary of this data, again, falls down to this: is the patients do better with immediate clot evacuation, everything from improving RV function to reducing incidence of post-CHF and post-PE syndrome as well. Reduction in the ICU stay because of the lack of requirements for thrombolysis. In some centers, these patients are being discharged in 24 hours. With no admission to ICU. They get sent either to HAU or to the ward after. So again, very promising data and findings. In response to the FLASH registry, there is the more newer, which is the FLAME registry. This was specifically looking at high-risk patients with PE aspiration technologies, again using the flow retriever device. Once again, the patients in both groups not being very comparable, again, being a very industry-sponsored study, so take it as you will. Biggest thing here being the numbers in these is they're shocking. They're absolutely amazing for whatever it's worth. Is if you compare this back to the context arm, which is whether you look at systemic thrombolysis or anticoagulation, your numbers are certainly better in terms of mortality, as low as 2%. Your incidence of bleeding is lower compared to patients receiving systemic thrombolysis. So again, very magical in terms of the results from them. Very small groups nonetheless. You have N of 53 patients here, but once again, this is a small group of patients to begin with. Very difficult studies to form nonetheless. So again, it really will, I think, come down to clinical gestalt, to clinical experience, and that's why we're trying to do as much as possible to gain those conversations early, start those meetings early about patients, and see which ones can be best applied to with these technologies. Going back to catheter thrombolysis, I think it's also important to look at that because we do offer this, and we have offered this in the past as well with good results. Unfortunately, we've not reviewed our data when it comes to catheter thrombolysis at St. Paul specifically, but it has been reviewed at other centers. So this was a paper presented at LINC, which is a major European meeting, which I attended last year. And this is a study out of Zurich that looked at over 1,500 patients, and they looked at all-cause mortality and major bleeding. And these are some of their numbers. So they found that certainly patients who were older had higher risk of bleeding complications. They found females, interestingly, had a more severe PE with a higher bleeding risk. And they interestingly found that patients with active cancer and recent surgery had no substantial increase in bleeding risk post-catheter-directed thrombolysis. Their bleeding rates were significantly higher compared to the aspiration-only cohort. But again, this was data that was not compared to any other context arm, but specifically looking at catheter-directed technology alone. Data that's going to be upcoming in the next few months to year. This is one such study. This is called a STORM PE study. This is going to be out of Penumbra. So the Penumbra aspiration device in comparison to anticoagulation alone. So remember, this is a 16 French device recruiting patients in 20 international sites with a 90-day follow-up. So again, data that's going to be upcoming. Along those same lines, I think the question then becomes aspiration versus catheter-directed thrombolysis. And this is the Peerless trial, once again, industry-sponsored. And this is going to be looking at Inari flow retriever versus catheter-directed thrombolysis in patients with massive PE. And this is supposed to be a prospective RCT study that's going to be looking at over 500 patients at 60 sites with a 30-day follow-up. So again, results of this will be crucial in advancing our understanding before we start using these very expensive devices. But the preliminary data has been very promising. So I think we'll stop there in terms of data and look at some real-life cases. The one thing that's going to be common in all these cases are these are all patients with massive PEs. I believe one case that Dr. Hergy was kind enough to provide me is a patient with an intermediate high-risk PE as well. But in general, these are going to be all patients with either massive saddle PEs, bilateral PEs, hemodynamically unstable patients. So this is the first case. This is actually my case. And you know, the first thing I would say before I talk about cases is this is a team initiative. And I cannot say that we have all the experience with PE because we certainly don't. Like I said earlier, the majority of our consults typically come very informally. I often get text messages from my job in cardiac surgery from the surgeon saying, hey, do you manage PE, or can you suck this clot out? And that leads to its own set of discussions. And I really want this to be a standardized approach, a standardized algorithm for this. And so I've taken cases that I've experienced, taken cases that my colleagues have experienced, including those from RCH and SMH, and brought together 4 cases that I think are very representative of what we see so far. So this was one of my cases. I was on call for actually cardiac surgery as a CA on that weekend when I got called for this. So this is a 59-year-old lady who came to St. Paul's with a non-op tib fib fracture a week prior, and she took her orthopedic surgeon's advice to heart of bed rest and remained in bed literally for an entire week. Was found down with a friend, had 45 minutes of cardiac arrest downtime, achieved ROS, was brought in as a code activation. And at that point, the preliminary diagnosis was a PE based on that history. She was seen by the cardiac surgeon as a code ECMO, and the decision was made whether or not we should do a VV ECMO. And so that's what I was called in for, was to assist with the VV ECMO side of things, which is one of my other jobs. But in that moment, it was a discussion it was Anson Chung was the staff on for this case. And we came up with a plan that, no, this is a patient who would actually benefit from immediate clot evacuation as opposed to surgical embolectomy or VV ECMO. And that's what we did. So I ended up taking the patient to the IR suite with one of my interventional colleagues. I believe it was Jason Clement on that night. And these are sample images of what we saw that evening. So this is on the CT scan, massive occlusive PEs on both sides, right and left side. And in that moment, we only had access to the Penumbra device. So what I ended up using for the interventionalists in the audience is we used a 12 French long sheath, parked it in the PA, and then we used the Penumbra Lightning 12 aspiration device, and we ended up only sucking the clot out from the patient's right side. The background of this case also was, given the prolonged downtime, this patient already had evidence of hemorrhagic transformation on the left lung. So I was concerned about aspirating the clot from the left side, to prevent a bleed. So we only ended up clearing the right, the RPA. And so these are some representative pictures showing that. So this was a pre-image, and you can see some of that white filling defect, which is the thrombus in the right lung. The angiographic images demonstrating decreased perfusion to the lung. And this is before. So the question was whether we do VV ECMO, whether we do catheter-directed thrombolysis, or surgical embolectomy. And this was a discussion down in the trauma bay with the family, where Dr. Chung, myself, and the IR staff. So we ended up doing catheter-directed thrombolysis. We ended up doing aspiration thrombectomy with the penumbra device. And these are our post images. The procedure time was about 35 minutes in total. Blood loss was about 300 cc's. And we had an immediate change, and I'll show you some of those numbers in oxygenation. So our oxygenation went from almost 60% to up to 94% on just 4 liters alone. She was intubated when she came to us as well. The issue with her, unfortunately, and this is a picture of her CT scan immediately after the procedure, because we did run into complications with her. Like I mentioned, she did have signs of hemorrhagic transformation prior to her procedure, which only became worse with reperfusion, which is what prompted the CT. But as you can see, we've cleared that entire RPA and outflow tract of clot using that aspiration device. So these are some of her numbers post-procedure. Her lactate coming in was 25, down to 15 minutes post. Her O2 sats from 70 to 94% on 100% O2. And so we were quite happy with these numbers. Unfortunately, given her downtime, given the strain on the RV, she did not respond well. So she did have a temporary increase in her blood pressure. We did not have echo that in that minute in the IR suite. Based on just hemodynamics alone, my concern at that point was for overall hemodynamics. So given we're in a center that has ECMO, given that we have staff with ECMO expertise, I put this patient on VA ECMO in the IR suite with Dr. Chung's approval. And so this is what the patient was put on, VA ECMO on both sides, and that helped stabilize her. Unfortunately, in this case specifically, she ended up passing away days later because of that prolonged downtime. She was found to have a large parietal stroke. And so unfortunately, the medical care was futile, despite her recovering her hemodynamics post-procedure, requiring ECMO, being supported, and then eventually being called palliative because of that stroke. So an unfortunate case, but again, one that shows the team approach to this condition. This is a case that Dr. Herges provided me kindly from RCH, 65-year-old female, similar circumstances, hypotension, shortness of breath. The diagnosis was a massive PE, given that hypotension, elevated troponins, right heart strain on CT. CT confirmed a diagnosis of bilateral PE. I'm going to show you a representative CT scan for this. So once again, if you look at the PA and the bifurcation, extensive clot within the bifurcation, expansion and compression of that septum, and increase in the RV-LV ratios as well. So again, all signs that this is a massive PE with extensive clot burden as well. These are the results that Dr. Hergy was able to accomplish. So he was able to gain all that clot out. Remember, we're not going distal into those subsegmental branches, but really clearing out those proximal upper, middle, and lower lobe branches. And he did this using the Inari device. And you can see some of those numbers there. So the patient came in hypotensive with a blood pressure of 115 post. Their O2 sats on 4 liters, normalized after. This particular patient did extremely well, remained in ICU overnight, and was discharged the following day. So a 24-hour admission for someone with a massive PE. These are some of his images after. This is post clot aspiration. Again, once you can see, this is a large device, a large circular hose, as you will, that is responsible for sucking out the clot and PE with immediate clot resolution. Along those same lines, another case from Dr. Hergy from RCH, a 70-year-old female with dyspnea, cough, chest pain, shortness of breath, presenting with an intermediate high-risk PE, so not a massive PE. She was hypotensive, normotensive, too hypotensive, elevated troponins, slightly tachy, but on room air at 94%. Once again, CT positive for a bilateral PE. So this was his representative images again after. Once again, using the Inari device, he was able to gain clot clearance bilaterally with normalizing O2 sats immediately post-procedure. So if you look at the CT scan images, on the first picture on the left shows that occlusive thrombus at the bifurcation. If you look at the second image over, you see that RV to LV ratio. And then finally, you look at the improvement in the angiographic appearance post-clot retrieval. So once again, demonstrating the immediate clot resolution and improvement in RV dynamics post-procedure. This is another case that I wanted to present. This is actually a case of mine, of our teams when I was a fellow that I did with Tim Murray and Jason Clement. Now, this is a patient that I presented to the ICU with a massive PE. IR was consulted. Similarly, hypotensive in respiratory distress with right heart strain. In that moment, we did not have the aspiration device technology. This was about 2 years prior. So given this patient had a massive saddle PE, as you can see in the CT scan, we opted to do catheter-directed thrombolysis only. So we did not do IV thrombolysis. And the technique for this is either a femoral or jugular stick in IR with 2 pigtails in the RPA and LPA, and we run 1 milligram of TPA per hour for 24 hours, and we do a repeat venogram the next day. And this is the venogram the next day. So complete clot resolution in this particular case. So I think that's kind of what I wanted to show you in terms of some of the good cases we've had, some of the bad cases we've had as well, especially the one I was involved with. The numbers are low at this point. And so I think the biggest take-home message here is I don't have, if you're looking to me for a firm algorithm that it's going to be right, that's going to be black and white, I don't have that answer, and I don't think anyone has that answer. But what I do have is, if you look at some of the algorithms that have been published out there, there's a lot of different nuances that can be addressed within your teams. But I think the biggest, most important take-home message is that conversation has to be had early and has to be had as a team with thrombosis, with IR, with ICU, with all the involved players, so that we can address whether or not a patient is a candidate for systemic versus catheter versus aspiration technologies, because that's what's going to benefit them, whether they're going to be the high-risk group or the intermediate high-risk group. These are some algorithms I found in the literature. Every one of them is similar with some minor differences, but I think there's always going to be some degree of individualization that's going to be applicable to each center, and I think each center is going to have their own version of this. And so these are from various centers across the country. This is the one that was most recently published in October by the group out of Fraser Health. And I'll let you to just ponder over this, and we'll just spend some time on this slide for a moment. And really what you can see in this is it starts with the radiologist who identifies the high-risk pulmonary embolus, and that leads down this pathway of whether or not they are high-risk or not high-risk. We'll focus our time on patients who are high risk. If they're high risk and they don't have contraindications to systemic thrombolysis, their approach is to move to doing systemic thrombolysis, whereas what we are recommending here is systemic versus catheter-directed therapy to minimize the dose of TPA involved. Now, I believe the ICU group here is looking at doing lower dose systemic TPA, and I don't know what that effect is going to be, but at this point, our recommendation from IR is systemic versus catheter, but that discussion be had as a group together for these patients. And then we decide whether or not we move to the aspiration-based technologies that don't involve TPA, or we do pure catheter-directed thrombolysis as well. But the goal being that rapid clot extraction to help RV function as well. And that becomes, I think, clear with the high-risk massive group. Where it does become murky again is with this intermediate submassive group. And the Fraser Health cohort looks at combining patients with both RV dysfunction and evidence of RV strain or based on the troponin elevation. And then again, if they are candidates for thrombolysis, then once again, our recommendation is we have that conference with IR, with thrombosis, with ICU, and decide what the best therapy is, and whether that therapy is catheter-directed therapy, which is pigtail catheters, or aspiration, or surgery, if that truly is indicated with cardiac surgery. And again, we have an excellent group. I have the fortune of working in all 3 departments: cardiac, vascular, IR, and I think we have the perfect substrate at St. Paul's to have these conversations. Even if we don't establish a set per team, I think we have that ability to come up with an answer for that patient, whether it's on the phone or in person, and then guide what the next therapy should be. So to give you an idea, so what's happening locally, VGH was the first one to start their PERT initiative here in BC back in 2016. Now, Zamir and his team have led the algorithm at RCH and SMH, and he's done several cases successfully with the Inari device and has been willing to proctor us and guide us through the initial development of this, and we're very lucky to have him for this. We also have Dr. Rav Dat from VGH, who's willing to help us establish this as well. But again, it's going to remain quite individualized to each center, and I think that's a good thing. I think that's important for us to take back, is that there's no right answer for this, and we have to remain open to having some degree of variation between the centers. And at St. Paul's, I don't know what that looks like. I don't know if this is going to be a PERT or whether it's just going to be a standardized algorithm and approach that's initiated by radiology. So finally, what I would say is, and I mentioned this earlier this afternoon as well, is the cost is going to be the biggest driving factor. The bed allocation is going to be an issue as well, whether these patients are going to be allocated to ICU versus CSICU versus HAU, where the funding comes for this. These devices are very expensive. And as a result, at least in IR, I know it requires 2 physician consent before we actually open up one of these devices, given its cost. I learned this the hard way the other night doing that case with Jason, is that we needed permission from our finance department before we moved into this procedure, and that makes sense. We don't have literature that supports this definitively. We do have some good results out there, but not enough to say as a blanket statement that we can definitively use these expensive aspiration catheters for PE. So I think there's a lot of lessons to be learned. I'm looking forward to our first algorithm patient. We're certainly going to have M&Ms in radiology, and we'll be closely following all the results of all our patients that are intervened on as well. And finally, we'll be reviewing the results and talking to our colleagues from RCH, from Surrey Memorial, and VGH as to what their experiences are like with some of these newer devices. So I think in summary, I just want to end off by saying that the outcomes remain poor in PE patients who are treated conservatively with anticoagulation alone. The mortality remains quite high, which I think behooves us to have some degree of a standardized approach to these patients, so that it's not just a single physician driven. We do have the optimal team environment here at St. Paul's with all 5 players, including thrombosis, ICU, vascular, IR, and cardiac surgery. And I think we all work well enough together that we can do this for our patients and in our catchment area as well. The RCT data is certainly lacking, and there are newer studies that are in the works, which will help guide us in determining whether CDT is favorable or aspiration is favorable. And finally, there are new modern approaches to PE management that are TPA free, and this can also be applied to DVTs. I know we've had a discussion with thrombosis, vascular, and IR as to better managing our DVT population with TPA-free technology, and I think this is the same extension into the PE realm as well. So with that, I just want to acknowledge the players at St. Paul's and thank everyone for their contribution for this, both in the patient care side and also in the presentation side. We have 4 very dedicated thrombosis staff here at St. Paul's, and certainly we have our vascular surgeons who are also involved in sometimes getting us that high acuity admission set up for these patients. We have 7 colleagues of us in St. Paul's and IR who do offer these procedures, and we have proctors like Dr. Hergy and Dr. Dat in the Fraser Health and VGH who will help us, with our first cases with some of these newer technologies, and then also colleagues such as Duncan in ICU. Who are going to be critical at helping us either source these patients, monitor these patients, and recover these patients after, and to help us decide what the optimal trajectory is in patients with PE. So with that, I will end there.